thank you very much for those of you that are part of the faith community for joining us. We're really honored to be partners with you in affecting the health positively of Riverside County. Really happy that Dr. Leung can join us, as well as Dr. Fayard. And so thank you both for joining us today. Actually, before we get started on this topic, I don't know how many of you were able to join our last discussion, which was really focused more on the medical aspect of things. And I'd just like to see if you have any specific questions or ideas based on that. I know one of the ideas that was brought up to me after the session was creating a brief educational video that could be shown to either congregations or other kinds of settings to help educate people about the benefits of masking and that kind of thing. And we're working towards that. So are there any other particular questions or thoughts that you had as a response that kind of came up afterwards that we could kind of either work to addressing in a different format? Today's discussion is going to be hopefully geared towards other things where we can partner to positively affect our community. So I'll give just a little bit of time to kind of think about that and raise any questions you might have. Okay, it looks like nobody had any specific questions or anything. So today we're really hoping to have a actual more of a discussion than we did the last call that we had, because we really feel like this is an area where we can partner together, and we really need the faith community's input on that, about how we might do that. And so I hope this will be a much more active discussion between our groups on how we can kind of move forward with this. I'm going to just share just a couple of quick slides really quickly on kind of the background of where we're approaching this topic from. And then Dr. Leung will present a little bit, and then I'll go through one of the documents that we might use for pediatrics specifically. So let me get to... So everybody can see my screen, correct?
Yes.
Yes.
Okay. So what we wanted to kind of briefly introduce the idea of is social determinants of health and adverse childhood experiences, and that these really impact people for their entire life in multiple different ways, and especially in a time like this where the economy is down, and there's a lot of other kind of effects on society that could either worsen or compound the already existing social determinants of health or adverse childhood experiences. We thought that this might be a really big opportunity to partner with the faith community to kind of work to identify these needs within communities and work together to address those needs. And so just wanted to give you a little bit of background on what social determinants of health are. This is one of the views. You can find a lot of different things that kind of look at the social determinants of health, but basically that it's a variety of things in our daily life that affect our good health or well-being. And so you can see here, economic stability is one of those things. And that obviously for many families has not been, there's not been economic stability over the last several months. And that probably is going to be something that's ongoing. And then the neighborhood and physical environment. So, what is the housing in the place where a family lives? What's the transportation situation for that family? Is it safe? Are there parks or playgrounds? Is it walkable in that area? Then there's education, literacy, language, early childhood education opportunities, which are somewhat limited in counties. And then what's the higher education opportunities? And then food, so hunger, access to healthy options, not just food in general, but healthy options for food. And some of you may have heard of the idea of food deserts, where there's just not good food options because in that community, there's more stores that sell liquor or other kinds of things, and then have small amounts of quantities of food, which is generally not near as healthy. And then there's the community and social context. So the integration and the degree of social integration for a family or community, the support systems within that community, community engagement. And this is where, I think faith communities offer a significant network to provide support, engage families, engage children especially, to support them with all of these other things that may be outside of their control. And there's as well the aspects of discrimination or stress that can impact this. So I'm seeing that the slide may not be advancing. So are you seeing the social determinants of health? I have moved the slide.
We see the title page still.
Shoot. Okay, let me try that again. Can you see it now without
the rainbow columns?
Yes. Okay, so sorry, this is what I was referring to. You're seeing the rainbow columns again? Or still?
Yes.
Okay. So the discrimination stress that can occur in different communities, and then the healthcare system that is available. So, the health coverage that a family has, the provider availability within their local area, the linguistic and cultural competency of the providers to provide care that is culturally competent for them, and then of course the quality of care impacts health outcomes as well. So these are what some people view as some of the social determinants of health. Did my slides advance? Are you seeing a pyramid now? Sorry to have to double check on every.
Still slide. Seeing columns.
Okay. So I'll exit and then we'll. Actually, I'm just going to exit it.
We see the pyramids now.
Okay. I'm just going to make this bigger so that that we can just do it from this, and then I don't have to go in and out. So this is a pyramid that looks at adverse childhood experiences and the way that those adverse childhood experiences, which are a little bit different from social determinants of health, affect health overall. And adverse childhood experiences are generally a couple of things. So either abuse, could be emotional or physical or sexual. Then there's household challenges, which it could include mental illness, divorce, or separation of parents, substance use, incarceration, domestic violence, and then neglect, so emotional or physical or medical. And so all of those things, as you imagine or well know, affect the lifelong health of a person. And so this kind of shows how that goes from the bottom, where it basically is the generational kind of trauma, historical trauma that impacts social conditions and the local context, and then you get these adverse childhood experiences which disrupt neurodevelopment, impacts the social, emotional, or cognitive aspects of a child, and teenager, then adult. And then adoption of health risk behaviors, and then that can translate to disease, disability, or social problems, and then contribute to early death. And so this really came about with a seminal study that was done with Kaiser, and showed that actually there was a significant impact on people's health long term as a result of these childhood traumas, which was pretty enlightening. And the other thing that's enlightening is how many people had four or more adverse childhood experiences. So their score was 4 or more. And for women, that was 15%, which is a pretty significant percentage. For men, that was about 10%. And that translates into a wide variety of different things in people's lives. So it can translate into injuries because of health risk or risky behaviors, so traumatic brain injuries, fractures, burns, mental health disorders. So a significant association between depression, anxiety, suicidality, post-traumatic stress disorder, and then maternal health. So unintended pregnancies that therefore higher risk of pregnancy complications, poor prenatal care, and then potentially fetal death, or higher risk of premature delivery, which impacts the infant significantly. Then also infectious diseases. And then where it was a little bit surprising initially was chronic diseases such as diabetes, cancer, heart disease, and that kind of thing that you wouldn't normally think of as related to childhood traumas. And then also, as I mentioned just a couple minutes before, with alcohol and drug abuse or unsafe sex, so risky behaviors. And there's obviously, ways that we could potentially counteract this with education and other kinds of things. And so those are some of the things that adverse childhood experiences and social determinants of health can impact, individuals, but then obviously impact a community. And I guess what I think I'm concerned with, and what Dr. Leung is, I'm sure, concerned with as well, is that, as we've decreased interaction across society necessarily because of COVID, we need to make sure that we have support networks within society to counteract that and identify needs that are present and figure out the resources to address them. And so that was kind of just a little bit of background. I'm going to let Dr. Leung turn it over to him to talk a little bit about his whole person care score, and then we can kind of get into how do we address this together.
Thank you, Dr. Versio. So I'm going to steal the screen if that's okay.
Yes.
And so, we think this is a timely topic, again, because of all the things that Dr. Versio already mentioned. And at Riverside University Health System, we've put together a holistic way of sort of measuring and thinking about health, which we think will not be very different probably than the way, the ways that you all think about health already. And lately, again, we've seen sort of just this convergence in which many different groups are having similar conversations. And although these all seem like different topics, whether it's coronavirus or the economy or protests about disparities and racism, we think they all get to kind of a larger piece in which our community is struggling, with sort of the final outcomes or the downstream impacts of many different things. So, health outcomes, crime, racism, economics. A lot of times the things that happen in the end, we try to deal with, but really the common piece is that I think now people are starting to look upstream. And so, what is the ultimate source, or what is the ultimate cause of some of these different issues? So we'll get into that a little bit more. Like Dr. Versio mentioned, I think most of us now accept that health is more than physical. And even though 20 or 30 years ago, most doctors were very much centered on a biomedical model of health, I think most of us now accept that health is composed of, a physical component, an emotional component. Resource utilization is another name for how often we're going to the hospital or the doctor or the emergency room, or how many medications we're taking. Socioeconomics, which includes a lot of things, everything from, employment and education to housing and access to food and transportation. And then ownership and activation, they're sort of a newer terms, but they get to this idea that, some of us, have more of a mentality that whatever life throws us, we will find a way through it. We have that we are sort of our own masters of our that we can have an impact on what happens to us, versus some of us who may have more of a victim mentality, feeling like whatever happens is not my fault, but things are happening to me. And definitely we know that can predict health, and people who believe they can have a positive impact on their health health, not surprisingly, have better health outcomes, and vice versa. And then finally, nutrition and lifestyle. And all those things impact how long we live. And, you know, most of us in the healthcare community, we're focused very much on the things on the left side, physical and lifestyle factors, things like blood pressure, smoking. You know, we're starting, you know, we're doing a better job quantifying exercise and diet. But the things on the right side can have just as dramatic impact on life years gained or lost. For instance, you know, having severe depression can take away 7 to 20 years of someone's predicted lifespan. And similarly, you know, level of education, finances of a family, you know, whether someone has a steady housing, whether someone is working or disabled or wanting to be working but not able to, religion, social support, how closely we follow our own health, you know, use of substances like alcohol and drugs, and then you know, where we live. All of those things can really impact our life expectancy and our mortality. So at Riverside University Health System, you know, we really struggled for a long time because, you know, with the medical paradigm of health, our reflex tendency is, you know, we see a patient, we want to make a diagnosis, a medical diagnosis, and then we want to treat either with a medicine or a procedure. We want to sort of solve that thing. But the challenge is that sometimes we miss sort of the larger picture. And maybe someone is severely depressed, maybe someone is, you know, doesn't even have electricity, maybe someone is caregiving or working 2 jobs. And if we don't take those things into account, we could spend a 15 or 20-minute visit talking about diabetes, making some changes with some medicines, and we could really actually be doing a disservice for the individual if they are experiencing challenges or issues that sort of take precedence from their perspective over that discussion about medicines. So this idea is we have a 6-letter score, 1 letter for each category of health: physical, emotional, resource utilization, socioeconomics, ownership, and then nutrition and lifestyle. And the first letter of each of those categories spells out person. So we also call it a person score. And each letter varies from A to Z, A being the best and Z being the worst. And we get these letters from actually an assessment that's a 28-question assessment based on elements that are all tied to how long, that are all related to longevity and mortality. And this is just an example of how we use it in the clinic setting, and we know we're talking about sort of faith-based settings and the wider community, but just so you have an idea, let's say we have a 52-year-old individual who might have diabetes, and we do this, you know, this 28-question assessment even before they start seeing the doctor, and we figure out that their whole person health score is kind of as listed, G, S, A, W, C, L, and remembering that A is sort of the best and Z is the worst in that category. If we only have 15 or 20 minutes to focus on this individual, you know, how can we best prioritize our time? And, you know, our hope is this with the 6-letter person score, you know, it's a reminder to the care team and the doctor that, you know, maybe in addition to talking about medicines, you know, that we might want to focus on an area like socioeconomics or emotional health where this patient scored lower. This is actually how the score looks in our electronic health record system. So it's not just a letter score, but it also has a color code, green being good, yellow being sort of in the middle, and pink or red being, you know, something that we need to address very quickly. And again, you know, the whole idea is to make it very apparent to not only the team, but also the individual as well, so that we can give this immediately back and say, you know, we've just done a holistic measure of your health, and we think your person score is, in this case, CRAOMP, and this is what we think it means. You know, how do you feel about that? You know, does that seem, does that make sense to you, or is that different than what you would expect? And then all of a sudden it can lead to different conversations. And it may turn out, at least in the medical world, that we reallocate our time, and instead of spending all of our time talking about a medicine or a test that a patient has to do, we might actually spend more time talking about how we need to get this person plugged in with a behavioral health expert or a nutritionist. And then the patient can also leave with a score, and when they've when they've done some work or connected with someone, they can always get reevaluated and see, if they're doing better in that area. So part of it is also to engage and to empower the individual. This is a listing of the elements that are sort of assessed when we do the whole person health score assessment. So you can see the 6 major categories, and the print might be small, but you can see that, again, in an area like emotional health, it includes, depression, anxiety, social support, prayer, meditation, meaning, purpose, sometimes things that are extremely relevant to individuals, but that, we don't feel like we have permission to talk about. And then, choosing just one more category, ownership and activation, things like self-rating of the health, which we know is a very powerful predictor of health, knowledge about one's own health, one's feeling about self-efficacy or self-management. So some of these elements obviously change faster than others, and things like housing and employment may not change as quickly as someone's mood. This is just an example of the type of question. So out of the 28 questions, this is a question about self-rating of health. In general, would you say your health is excellent to poor? And then we put a point, we sort of scale and weigh those answers. And then we take the composite of those answers for each category and then resulted in a letter, sort of letter score. And the reason we use letters is because patients actually have told us when we were developing this, patients told us that letters made much more sense to them than numbers or percentages. So while the tendency for the scientific community is always to use numbers, this really was built to be patient-centered, and especially for individuals with low literacy who might not have English as a first language, or just people in general. This is the feedback we got, so we built it around that. So, just a couple final slides. When we use this approach, which is trying to look at people holistically, there are kind of some natural next steps depending on, whether people are scoring low in a certain category, and the services that you may have to offer may vary depending on who's doing the assessment, whether you're a community organization or a faith-based organization or a clinic. And these are just examples of the types of services that we offer to our patients if they score lower in a certain area. And so I'll stop right there in case there are any questions. Thank you for allowing us a little bit of time to share. And again, the reason, taking a step back, that we wanted to share this was, we think that a lot of things are happening right now. We have infection, we have, protests, we have joblessness, we have, stressors at home, we have, people kind of really having important dialogue about disparities and racism, and a lot of people who are struggling for different reasons. And so this is just kind of one framework or paradigm that we're using to try to make sense of things that we wanted to share and open up for discussion today on. So thank you.
Thank you, Dr. Leung. Yeah, you're right. This is just a paradigm that we wanted to let the community know exists, and see if is that something that you would be interested in. I'm just going to show really quickly. We do have something that's similar for pediatrics. It's not quite as we don't have the letter scoring, which is awesome. I'm so impressed with what Dr. Leung's team has done for this. But we do have a screening tool that we can use. We call it in the clinical setting the whole child assessment, and it looks at adverse childhood experiences. It looks at things like diet. It looks at kind of parenting responses to situations and that kind of thing. And it also looks for the caregivers at risk of depression or anxiety, and then some risky behaviors as far as even things like safety about water or wearing helmets and that kind of thing. And so, I just wanted to show that really quickly. And then C, with those of you that are participating, is this something you would be interested in pursuing, utilizing either of these tools? And what do you might envision as potentially coming out of this? And would there be interest in developing some work groups to kind of dive into these topics in more depth?
And Dr. Versi, I think, I would just add again, I think, especially in the faith-based community, a lot of these concepts, we may already take for granted. I mean, we may be doing these, thinking about these different areas, whether very deliberately or kind of, just in the back of our minds. But I imagine that, these are things that you're already considering. I think one of the differences is, could a tool or a framework help you with supporting members or individuals in your community?
Right. Or even potentially outside of your community.
And maybe another question, Dr. Versio, is, I am curious how, people on this call or webinar today are currently thinking about whether it's social determinants of health or adverse childhood experiences, and how you currently go about supporting your communities right now.
So I think, Holly, thank you for putting your comment into the chat. Not sure how you would use them in the parish. And that's a very valid question. That's really what we wanted to know is, would you be interested in figuring out how these could be used in a faith community setting? One of the ideas that that I know one of my colleagues in pediatrics, or she's actually preventive medicine, is interested in, would there be interest in offering parenting classes within your parish or your faith community, that you could potentially identify these people that might benefit from that or be interested in that based on one of these tools? So that's just one simple way. And there's probably a lot of other things, nutrition or nutrition classes or that kind of thing. And so, yeah, that's why we wanted to see, is this something that that the faith community would be interested in partnering on, and then we could work towards figuring out some of the resources to address concerns when they are identified. So it looks like Holly is saying yes. So are there other people that have thoughts on this? We really want this to be kind of a discussion and time for questions, talking to us about thoughts that you might have about how we could even improve this. So Dr. Fayard, I'll call you out. I know you've been working with the diocese quite closely. Is this something that you can kind of foresee being used, or others from the diocese that might be on the call, that we could see using these tools?
Thank you, Dr. Versio. You surprised me on inviting me to a comment. I think that potentially that can be the case. I think that what I would envision is that how these tools can be connected to specific outcomes. So, for instance, if, say, a given parish that's provide this administers this tool. So say that then you collect it, then what happens with it? What do you do with it? Where do people go with it? I think that this is a very granular needs assessment, if you will, that allows you then to really target and deploy an intervention on a population. So I think the rippling effect and impact as to how these can work can be really quite fantastic. But I think that maybe you might need to sort of think through how you can do it, and then once you collect it, then what happens with it, and so I think that there's some room for individual consultation. Imagine people that fill this out. For instance, Dr. Garcia, if I may, maybe I'm talking too much now, but so as you know, we do these health fairs at Catholic Parish. So people come in, say they fill that out, then you have a beautiful map as to what it is that this individual may need. I also can see that if you have more of a massive administration of the tool, then you can have a map for the community, not just individuals. So then you sort of can deploy resources in some way. So I think that the key will be in how you bridge the rich information you're collecting so that people can see, oh, if I do this, then I'm going to be able to access these elements that will make me thrive and help my family thrive, and so on. So that's the way I think about it. But I'm just thinking out loud, Dr. Garcia. So I'm not sure that I'm making a lot of sense. But that's, I guess, my initial response to what you presented.
Absolutely. I think that makes sense. So I actually wanted to ask a quick question for Dr. Leung, because I'm trying to think of, one of my concerns or what I would not want to happen is that a family or individual gets screened with one of these forms, and then that's all that happens. Concerns would be identified, but nothing happens because there's no resources to tie them into. And so, that would be absolutely what we want to avoid. So in asking that, Dr. Liang, I'm wondering about the complexity of, I think your whole person care score would be available on paper, but would there be a possibility, I know it's currently built within Epic, but would there be a possibility of scoring people with getting a really kind of that robust automatic scoring that takes place with filling it out electronically outside of Epic, or can people fill it out in Epic without having an encounter in one of our clinics?
Yeah, so that's a good question. So a couple comments. So first of all, we are having it built into just our regular website, so that if there is an interest, there probably it might be password protected. I'm not quite sure yet, but there probably would be a way, if people wanted to utilize it, and that way you could have somebody enter into it, and then you could get the automatic score, and maybe you could even get a copy of the answers, or a PDF or whatever you might need. I think to get to sort of the larger question, this is just a tool, and we are not saying that this is a solution, and definitely kind of taking a step back. I think each of us would have to think about, are there any challenges or opportunities that we are trying to address right now. And as Dr. Fayard mentioned, it's one thing if maybe you have a church that's already participating in health fairs, or maybe you have a group that addresses a certain area of need, or there's a support group. I think it makes the most sense if you start off with a challenge that you're trying to address, or maybe it's a group or an individual that you're trying to support, and what are the ways that you do that now, and are there ways that we can help partner or support in that? So I don't know, I'm probably not saying it very clearly, but I think what I'm trying to get at is you'd really have to start with your purpose or your challenge first, and then think about what you're trying to achieve, and then if there's some way that we can help or partner with that, we'd be happy to. I think the reason this dialogue came about today is we started hearing from the community, the broader community, that there were many different challenges that were arising, you know, in the lives of families that may be slightly different today than before the coronavirus epidemic started. And given all of that, you know, what are some tools, what are some different ways that we can think about supporting, you know, our members or our, you know, parishioners in different ways?
Yeah, and we have Dr. Ariane Mary Mitchell has joined us, who has been the primary person to develop the whole child assessment. You know, in my mind, if you know any of you are interested in utilizing something like that, we would want to kind of do an assessment of the resources that are already available within your community, and then figure out is there anything that, you know, we could help with identifying additional resources that could be caught with the screening tool. So, you know, if you already have parenting classes ongoing, then you may not need that. If you don't, then that might be something where she, you know, Dr. Ariane Mary Mitchell could assist with either teaching parenting classes or helping you develop that within your community. And so, so I think that there's, you know, lots of potential that we'd like to partner with the different faith communities across the county on. But we wanted to make that available and see what the interest is. Dr. Leung, you're muted.
I'm just looking at the chat box, and I'm seeing that Dr. Fayard had asked whether the tools are translated into Spanish or other languages. So the whole person health score assessment is translated into Spanish, and I believe the whole child assessment is too. Is that correct?
Yeah.
Yes. Yeah.
So is this something that those of you that are on the call, are you interested in doing this? And you know, it seemed like Holly was interested. I didn't hear anybody else so far. So if you are, please let us know.
Chad, this is Ariane Mary
Yeah.
Mitchell. I just expand on what you were saying. I think as I understood the conversation, some of the intent here was to look at opportunities to identify families that need more support or help. And this is one approach that, you know, Dr. Leung has been using in his working with adult patients, the whole child assessment. I've been using working with pediatric patients, you know, and identifying families that need help, that's definitely an important first step. You know, but it strikes me that, you know, the next step is arguably the more important one, which is helping and supporting the families. And that's, to me, where faith
Right.
communities can play a really important role. And, you know, related to that, a lot of what we see, at least on the pediatric end of what is needed is we have a lot of families, as you probably well know, who are very isolated. They don't have a lot of social support. They don't have good relationships or nearby relationships with extended family. And because of whatever's happened in their lives, things are complicated. And that's partly where I think parenting groups can play an important role. And it's that parenting group is offered at a faith-based place that becomes a sort of double advantage, because beyond the, you know, if it's an 8-week or 16-week or whatever the length of the parenting group is, beyond that, people have now connected with other families with kids their age within that faith community. And it's just a nice way to generate community, which is a lot of what needs to be done to help address adversity.
Thank you, Dr. Mitchell.
Sure.
Okay, so does anybody have any other thoughts or questions? Christine, if you don't mind putting the email in the chat so that people can see that and then email if they didn't feel comfortable speaking on the call, then they can email that and let us know that they're interested in further discussions on this.
You know, Dr. Versio, I don't know if, you know, before we end, if you want to take any time to ask if there are any other suggestions for future topics, or there were other things that people wanted to discuss.
Right.
Yeah.
Okay, so I think Christine is occupied. So I put into the chat the email, which is webinar@ruhealth.org. And then, yeah, please let us know if there's additional topics, or if you have any thoughts about this topic. We definitely want to hear about that.
I'm curious because I've in my internship last year, I know that there's an organization in the city of Riverside called Faith in Motion, that they bring a variety of churches and organizations together, and they exactly to meet the needs of various families. Would you be willing to do a presentation at organizations such as that? Is that something that you guys would want to do to get more involvement?
Yeah, absolutely. I speaking for Dr. Leung, I know I am.
Dr. Versio knows me very well, so you can.
And I'm sure Dr. Mary will be interested as well.
Yeah, sure. I mean, Dr. Liang, we could either do something jointly, or we could do a pediatric version and an adults version. You know, both of us, our work is very much focused on prevention, and you know, the more community awareness and engagement, the better.
Hi, my name is Irene Capin, and I actually manage Faith in Motion for Riverside County. So, yeah, I'd love to touch base with you. I am here and love to see what we can do and work out.
Okay, wonderful. Yeah, if maybe we could just schedule a call separately with you to kind of discuss what presenting to Faith in Motion might look like, or that kind of thing. That would be great.
Sure.
Tell us a little bit then more about Faith in Motion itself, while we have a little bit of time left.
Oh, of course. Faith in Motion is a Riverside County program created from DPSS, and I link faith communities to the foster care system. I will help guide faith communities to create ministries to support the foster care kids. And then also I guide families through the system. I myself am a foster adopt mom, so I've done it for 6 years. And we help everyone through all that. And that's what we do.
Okay. Wow. Oh, so this is something very much you see on a personal basis.
Yes. And as a matter of fact, we were having Faith in Motion meetings yesterday and today, and I promoted this webinar because I went to your first one, and I thought it was very informative, and I thought it was I think it's great that we have experts to help us through this unknown crazy time.
Yeah. So how many faith communities do you have connected to Faith in Motion?
Well, let's see. I am working I have like 42 active members that are partnered with us, but
Okay.
I am working towards 274 faith communities. I'm still trying to, a lot of it, as you may experience, is educating who we are, because Faith in Motion was created by Riverside County, and so it's a great program, and so but most churches don't know about it, so I'm trying to reach all of them.
So I'm going to call out somebody else who I think is still on the call, though I'm not sure. Justin Kim, are you still on the call? Looks like maybe not. I will, so yeah, if we can connect, because I think it would be wonderful to partner on this, and potentially connect Faith in Motion with another group as well. So any other additional thoughts? I know Dr. Leung is winding up his time with us. Thank you for joining us. Anybody else have any additional thoughts? We definitely want to make this, a bi-directional partnership and not something that, we really impose anything. Okay, we'll look forward to further discussions on this. So Christine and Amanda will help us with that, and especially with Faith in Motion. The other thing I think opportunity we may have is with the Interfaith Council that I believe is operating in San Bernardino and working to kind of roll these out potentially with that as well. So thank you for joining us today. Sister Chiley, if you can think about maybe how these tools might be utilized within the parishes, and we can work with Dr. Fayard on that as well. And let us know what thoughts you have. I think Dr. Leung and I are both highly interested in engaging with whatever faith community is out there to improve the identification, but then of course, as Dr. Mary Mitchell was saying, the actually utilization or access to resources for families. So thank you for joining us today. Please email us